to take these medications at nighttime, but that's not ideal. So you always just make sure you educate them always in the morning, so they can, when they're awake, they can get up, they can go to the bathroom. No nighttime, because it's gonna kind of disturb their sleep, and that's not good either. Okay. So next one, we have a loop diuretic, which is Lasix, or we have also torsemide. Make sure you know both names for Lasix, and that Lasix is also a furosemide, because you guys might see, one of those names on your exam. So it's good to know that Lasix is also a furosemide. Okay. Loop diuretic, Lasix, is commonly used in people with congestive heart failure. That's like the best diuretic for fluid overload. It also reduces hypertension, and it reduces that edema. Side effects are almost the same as with the thiazide diuretics: dizziness, headache, weakness, and hyperglycemia. Orthostatic hypotension, and again, electrolyte imbalances. So what are we going to do? We have to monitor their weight. We have to monitor their vital signs. We have to monitor their intake and output. The same thing, right? We have to monitor if, we're giving this patient Lasix, if it's effective, if it's working for them. Is there a change in their edema status? Is it less? Is it more? So again, Lasix, when it comes to giving a Lasix, we can also give it through IV. If we're gonna give Lasix through IV, we have to push it slowly, never fast, because if we're gonna push it fast, patient is gonna have a hearing loss. So make sure whenever you need to push IV Lasix, it's gonna be slow push to prevent that hearing loss from happening. Again, the same thing. The patient needs to take this medication in the morning, never at nighttime. And we need to educate the patients that if they gain, let's say, 2 pounds overnight or 5 pounds during the week, they need to let us know, because that's the fluid overload. There's just no way that you're gonna have a person that's gonna gain 5 pounds in 1 week, no matter what they do. So just make sure you do educate them on that as well. So this one, potassium-sparing diuretic is a different diuretic than the other ones, because it's a potassium-sparing one. So one of the side effects when taking this medication is patients are gonna have hyperkalemia, which is increased potassium levels. As you've noticed with other diuretics, when the loop diuretic, thiazide diuretic, and osmotic diuretic, patients will usually have hypokalemia, which is low potassium. But with this particular diuretic, spironolactone, they're going to have increased potassium. You guys need to know this. Just think about this diuretic as, okay, it's a potassium-sparing diuretic, which means increased potassium levels if the patient is taking it. So that's the only difference with this diuretic comparing to the other ones. You guys need to know that the potassium-sparing diuretic is a spironolactone, okay? Patients also will develop low blood pressure, dizziness, headaches, and distress, but the only difference is high potassium. Nursing process, the same thing. We have to monitor their vital signs. We have to monitor intake and output. Daily weights is the first thing you would do. So how are you going to monitor daily weights? Let's say you have a patient that's in the hospital, and you have to, monitor the intake and output. What you're going to do is have the patient void after night, and then after that first void, you are going to start monitoring how much they take, how much they, how much they're urinating, and all that stuff. So always after that first void in the morning. Again, this also needs to be taken in the morning. It has to be taken with the meals. But with potassium-sparing diuretic, we need to instruct patients to watch for foods that are high in potassium, because this medication will already increase their potassium, and if they're eating foods that are high in potassium, that's gonna cause even more issues. Too high potassium levels. Normal potassium level is between 3.5 to 5. So you guys also need to know the range of potassium. Okay. Osmotic diuretics. So mannitol is one of those diuretics. This medication is commonly used in hospitals, most likely, because it can only be given IV. So it's for people with increased intraocular pressure, increased cranial pressure, and also this medication also prevents the kidney failure. Side effects: fluid electrolyte imbalance, nausea, vomiting, diarrhea, pulmonary edema, and increased heart rate. So since this medication is only given in the, most likely in the hospitals, because we only give it through IV, our job as the nurses is to make sure that we give this medication slowly, and we monitor the IV site for any infiltration, like pain around that IV site, redness, swelling, and tenderness. So, respiratory medications. Now let's start with the leukotriene blockers, and one of the leukotriene blockers is called montelukast, which is also singular. It reduces the inflammatory process and decreases the bronchoconstriction. Okay, it's commonly used in asthma and also prophylaxis of exercise-induced bronchospasm. People will have dizziness, headache, and confusion when they do take this medication. But what you need to know and educate your patients on, that this medication is usually taken once a day, and it should be taken at nighttime, because patients who have asthma, they usually have harder time breathing at nighttime. So if they take this medication at nighttime, it's gonna kind of alleviate or relieve those symptoms of asthma, and it's gonna be easier for those patients to breathe and sleep. We need to educate patients what to look for when it comes to asthma symptoms. But when we do monitor patients, like in the hospital, we have to assess for the wheezing, which is a common thing that goes with the asthmatic patients. We need to assess for decreased breath sounds, cough, and any sputum production. So, important thing about it, again, it's taken once a day, and it should be taken at nighttime. Selective beta-adrenergic bronchodilators. So we have short-acting and we have long-acting. So the short-acting bronchodilator is going to be albuterol, and the long-acting is going to be salmeterol and metoprolol. Okay. Those medications, they relax the muscle in the airway, which opens those airways, bronchodilate, right? So it's again used for asthma. It can be used in acute bronchospasm or any bronchospasm prophylaxis. Side effects: since it's a bronchodilator, everyth's gonna be happening very quickly. So patients are gonna have palpitations. They're gonna have tachycardia. They're gonna have a lot of rhinitis. Those patients are gonna have difficult time sleeping, and they will be very tremory. They're gonna have a lot of tremors. So you guys need to know that those are some of the problems that are associated when taking these. Make sure you know that if they do take a bronchodilator, just think about it that everything happens so fast. So everything's gonna be just hyper or increased. High heart rate, palpitations, difficulty sleeping, and tremors. So the patients is gonna be very hyper in general. For the nursing process, we need to know that the albuterol has a rapid onset of action. It's used with acute asthma attacks, and it can be repeated every 20 minutes. So our job is to monitor the vital signs and the patient's respiratory status. And we also need to educate the patients how to use an inhaler. How are they going to use this? Do they know how to use it? And they do need to clean your books says that they need to clean the inhaler weekly with warm water. But I would recommend, if the patients are, cleaning their inhalers after each use, and they also should rinse their mouth after each use, because, in mouth we have multiple bacteria. So if they're just gonna clean their inhaler every week, just think about it, when they're putting it in their mouth, how many germs are already on there. So it's better to just educate them that, do it daily, and again, rinse your mouth after each use. Anticholinergic bronchodilators. So those medications are tiotropium and ipratropium. Okay, so they're used to maintenance treatment of like bronchospasm that's associated with the COPD. It comes in the inhaled form only. Some of the side effects are dry mouth, constipation, patients may develop depression, insomnia, headaches, but most importantly, urinary retention. So we need to monitor patients for the urinary retention. Okay, you guys need to know this. We again need to assess patients for wheezing, decreased breath sounds, cough, and sputum production. We have to make sure they stay hydrated. We have to monitor their output, how much they are urinating. So obviously not everybody's gonna urinate every hour, right? But the way we measure the output is by like doing, how do I put it? Okay, the patient should void, let's say if they're voiding every hour, they should void at least 30 mLs per hour. Obviously, they're not voiding every hour. So if you have a patient that didn't go for 5 hours, and then in their 6th hour, all of a sudden they go and their output is at 500, that's okay. That's normal, right? But that's how you would know that the urinary output is still normal. If you have a patient that hasn't voided in let's say 8 hours, and then all of a sudden they go and there's only 100 mLs of urine, that's not good. We already know they're retaining the urine. They cannot fully empty their bladder, so that is the red flag. So 30 mLs per hour is like a normal range. Patients who take the bronchodilators, they should also avoid caffeine, smoking, and they should know how to use and maintain the inhaler, and how to when to rinse their mouth, how often, and how to take care of the inhaler in general. Now we go into steroid inhalers. Beclomethasone and fluticasone. Okay, so they're maintenance therapy for COPD. Very common side effect is thrush. So again, most of those inhalers are going to come in powder form, so we have to educate patients to rinse their mouth after each use to prevent the thrush from happening, because once they get it, it's very painful, very uncomfortable. We will monitor patients' vital signs and respiratory status. You guys need to remember that bronchodilators should be administered before steroid inhalers. Okay? So bronchodilators always go first because they are short-acting. And the steroids are usually like a long-term use. Okay. Our next bronchodilator is theophylline. You guys need to know that it relaxes the smooth muscles of the bronchi, and it decreases the response of the substances that cause the airway to constrict, which it promotes that bronchodilation. It's used in asthma, and the common side effect is increased heart rate. Make sure you know the therapeutic levels for this medication. So the normal range is between 5 and 15, but we consider a patient toxic if their levels are greater than 20. So if the patient is already at 15, for example, we will keep a closer eye on this patient to make sure they don't go into that toxic phase, okay? Patients who take theophylline, they should not drink alcohol or should at least avoid it. They should not chew or crush the medication, and also depending on what they're eating, we kind of have to have a better idea, a better picture of what their diet is composed of. Are they eating a lot of carbs? Are they eating a lot of proteins? When they do eat a lot of carbs and proteins, or if they maybe take too low, this can have a huge effect on this medication, because if they're not eating properly, it's going to affect the levels, and the medication is not going to be effective as well. So just keep that in mind. Okay.
Professor, which one is the long-acting and which one is the short-acting?
What do you mean? Which medication?
The bronchodilator and the steroid inhaler.
So bronchodilators is a short-acting.
Okay.
Steroids are usually long-acting, but bronchodilators can be also long-acting, but that's why the bronchodilator should always be taken first, because it acts quickly, it opens those airways fast. Okay. And then you can start taking the steroids after. But that's 5 minutes in between. You don't take them at the same time. If you have, let's say, acute asthma attack. First you take a bronchodilator, 5 minutes later you can still take the other one.
Okay.
Okay?
Right.
Mm-hmm. So, bronchodilators, let's say albuterol, those are usually on an as-needed basis. So if you ever have a patient that takes it, you will probably see, take 1 to 2 puffs every 4 hours as needed. So that's only if the patient is really having hard time breathing, right? But you have medications like Advair, which comes in the disc form, or other the powdered inhalers. Those are usually scheduled, so patients do need to take it every day. Depends on, how severe their asthma is. It's usually once or twice a day, but those are scheduled, not only as needed. That's a maintenance. So they have to maintain taking this medication in order to prevent those asthma attacks. Does it make sense?
Yes, thank you.
Okay. All right. Let me just, do you guys see anything right now? Did I stop sharing my screen? I don't know, because Teams, I'm not very...
Stop sharing now.
Let's see. Let's try something else. I don't know. We'll just leave it as it is.